me, or you can save it till the end, or you can put it in the chat and we'll answer them at the end. Please don't be shy. This is not a formal session. I'm not a professor, so feel free to interrupt me. Okay, so this is a picture that I've stolen off Google. Shout out to Sarah Hudson. She made this. I just copied it from her. But basically, this is a very simplistic overview between you as a medical student / graduate and becoming a consultant. And it depends on obviously which specialty you're interested in. But regardless, if you're going to the UK and you want to become a consultant, you have to go through foundation year. It doesn't matter, non-negotiable. You have to do 2 years of foundation year training. So ideally, you graduate, you apply, you get a spot, and you go into foundation year 1. And usually the rotations are 3 jobs, 4 months each. And then it's the same for FY2 as well, as it's 3 jobs, 4 months each. Some places are different, depending on demand. They need more people, they need cover. So it'll be 4 jobs, 3 months each. And basically this is what you're ranking for, these jobs that you're going to do for the year. Once you complete your FY2 training, you're now eligible to apply for specialty training. So, let's talk about medicine, because I know a lot of people want to go into medicine. So then you have to apply for IMT training, which is internal medicine training. And it starts off with just the core training. So that's CT1, CT2, CT3. And then once you do that, you apply again for whatever specialty you want. So like you want to do cardiology, oncology, I don't know, pediatrics. I think pediatrics is part of that. I might be wrong there. But that's the structure. For surgery, it's very similar. You finish your foundation year training, then you apply for a spot in core training, and you do core year 1, core year 2, and then you apply again for whatever specialty of surgery you want. Now, there's certain specialties like ophthalmology, neurosurgery, I think cardiothoracics, I think obs and gynae. They are run through. So you only have to apply once. And once you're in, that's it. You're in the system, you have a training number, and you're going to go from ST1 all the way until you're a consultant. Obviously, there are requirements that you have to fill out while you're doing it, but you have a spot, like you're done in that sense. With medicine and surgery, it's different because you have to keep getting the things you need to apply and move on to the next step. And then GP training is also kind of more straightforward, is that once you finish foundation year 2 training, you apply for a GP post, you do 3 years of GP training, then you're a GP. I think this is important to know because, again, if you're considering the UK, you need to know that this is the road that's ahead of you. And I think it's also important because there's a lot of things that you can do to prepare for those like barriers to get into the next stage. So like, for example, I recently found out, because I'm thinking of going into surgery, what the requirements for ST3 is, which is like down here, like over here, like I can do like extra education, like a postgraduate diploma in teaching, and that'll help me here, but I can start doing it from here. And the other thing is that things that you've done in medical school, so anything that you've done since you've joined medical school can be used along your process of going through these steps. So don't forget all the conferences that you've attended, all the research you're probably not going to forget, but like all the surgeries you went into and you actually scrubbed in, there's a logbook for that as well. All the, anything that you've done, all the experience that you have, document everything. Basically, just document everything. It will help you later. Don't think that, it's small, I don't need to remember. It's really, really helpful later on. I'm going to move on now to the wards. So this is a really simple design, I hope, of what my ward or a ward in my hospital looks like. Now, obviously, there will be differences. I'm not going to say that, I promise you, whatever hospital you go into, this is what it's going to look like. Obviously not. But just to keep it really simple, usually what it is that there's usually a reception area, there are bays, which have multiple beds, and then there's side rooms in most hospitals. And then if you have a surgical assessment unit, which there are SAUs or surgical assessment unit, MAUs or medical assessment units, PAUs or pediatric assessment units, usually what it is like like 5 or 6 beds with some chairs that people can come and sit, and you can like eyeball them and stuff like that, and then assess them in one of the beds, and then you transfer them to a ward if they're inpatient, or you discharge them. It's really, and then usually, now this might be different if you're going to like a high tech center. You probably have everything digitally, so you don't have this. But our wards have a board everywhere. So there's usually a board, which in any ward, I can walk into any ward and I can just look, where's the MDT ward? I need to find my patient, you know? Usually there's a board there that can help. Our doctor's office is really tiny. We actually have 4 computers, not 2, but I couldn't put it in the image. And we go there and we make the lists and we, you know, put all the labs on a piece, like in a document, printed out. It's really prehistoric, but that's what we do here. I made this just to orient you with, like, when you walk in, it looks really chaotic, but this is the overall structure of how most wards are. In most hospitals, actually, it's kind of similar to this, but it's specifically in the UK. Side rooms are kind of relevant just because patients get moved to side rooms for, so far what I've seen, for one of 2 reasons. One being that they have an infectious disease, something that they might transmit to somebody else. We put them in a side room. Obviously, you don't want them to pass that on to anybody else. And the other one is that they could be passing away. So just keep that in mind, that if the other third one is they could be just traveling from somewhere else and you don't want them to mix with the population. But that's why they might be in a side room. So just keep that in mind. And then usually the bathrooms for Bay 1 would be here, and then bathrooms for Bay 2 would be here. So if you can't find your patient here, but they're meant to be here, they might be in the bathroom. So just consider, like, just walking over and just being, oh, they're in the bathroom. There's supply rooms in every ward, and that's really important because now you guys are not medical students or graduates anymore, you're doctors, and you will have to go and find your own supplies to do things sometimes. We'll talk about this in another lecture, and we'll talk about what supplies you'll need and stuff like that. But it's always handy to know where the supply room is, at least for the ward that you're covering for 4 months. You should know where they are and where all the supplies are. It's always good to keep an eye out. It's really helpful. Like, seniors come in, they want to do something. They probably don't want your medical advice, but they would love to know where this syringe is or the NG tubes are. So that kind of stuff you can really help out with. So it's useful to know. A sluice room basically is where they, like, wash things and, like, all the, like, the dirty things that need to be cleaned are. A lot of times, like, pads and diapers are in there as well. It's really handy to know where it is. I think personally, I feel like I'm rambling a little bit, but hopefully this is helpful. We'll move on now to the uniforms. Now, a huge disclaimer: your hospital may not follow this in any way whatsoever, but I put this slide here because I just want you to just take a second to appreciate how many different types of healthcare workers there are in the NHS. There are nurses, we know that, but there are so many different managers, so many matrons, so many physiotherapists, they're porters, they're ward clerks. There's so many people working. When you go to your hospital, just take it slowly, but try to figure out what does a porter look like? What does a nurse look like? What does the head nurse look like? What does the matrons look like? What do the ward clerks look like? The ward clerks in the NHS, most of them actually wear this shirt, which is really nice, that no matter what ward I go into, they're wearing this shirt. Also, just to introduce the concept of a ward clerk just sits at the reception of a ward, and they usually know where every patient is, and that's very helpful if you're trying to find a patient. They're also responsible for all of the paperwork, like discharges and referrals, just documenting everything. They're really helpful in that sense. There's also HCAs as well. Now, I can't see where they are, but I'm sure they're here somewhere. So they're healthcare associates, and they're kind of like nurses, but they do other roles that nurses, like they do non-medication roles most of the time. They're very helpful though, and they're very nice. And if you ever need a chaperone, I always just go to an HCA rather than a nurse. So it's just helpful to know. I think just having that in your mind, that there are going to be many different people who are going to be working with me. I think that's just something helpful in general. The next slide will be kind of boring, I guess, because most of you probably know this, but I think it's worth running through it again anyway, just really quickly. So now the NEWS 2 score, or the National Early Warning Score, is just a way that we communicate patients' vitals to somebody else really quickly. So if someone comes to me and is like, doctor, the patient's using 7, I know what that means, as in, like, there are a couple of parameters that are off for them to be using 7. Okay, like, you can't just use 7. If everything's normal, they're not going to be using 7. Or if a nurse calls me and say, "Doctor, I'm really concerned about this patient," I'll just ask, "Oh, what's their news?" They tell me 0. Then I obviously I'm going to go see the patient, but I'm not as concerned as someone when they call me and say, "Oh, there's a news 7 or 8 or 9." The way that this score is made up, obviously you guys are very smart people. You can see that depending on their vital parameter, they're given a different score. So you just add the scores up. But again, just keep it in mind, this is not an abstract concept that you studied once for an exam that you just you know it. This is something that you need to use every day on the wards. Usually it's a sheet like this. Now I hope that this works. Fantastic. Okay, so this is going to be a demonstration of how the news sheet works. Now, in a lot of hospitals, this is done digitally. You just get the end result, but I think it's really useful to actually run through it and see how do you calculate a news score. So that way, A, if you ever have to do it yourself, which I've had to a couple of times, you can actually do it. And then B, you can see what the nurses have to do to get you that score. So let's say at 10 a.m. you have a patient. They've come in, their respirate is 15. They're saturating at 97% on room air. Their blood pressure is 130/82. Their heart rate is 81. They're alert, and this is their temperature, which is 37.2 degrees. Does anybody want to take 1 minute and tell me what the news score is? Please feel free to shout out. Okay, that was pretty good. I think that is right. I don't actually remember what the answer is, but I hope the animation's appearing. So that's basically what you do, is that you take all the parameters. I think you can zoom in. I think you can zoom in on Microsoft Teams, so please do. And you just put all the parameters into the boxes. It's really simple. Like I said, for blood pressure, you only just put the systolic value, not the diastolic. Pulse, temperature, or consciousness level. And then you get the score, which is 1, I think. 0, actually. So all the parameters were normal, and this is a new 0. But now I'll show you the utility of this system, is that, let's say in the next 4 hours, which is usually how often nurses take vital signs, if they're normal, if everyone, they're fine, there's nothing to be concerned about, they take vitals every 4 hours. So let's say the next time they take vitals, this is what you have. Can we have this session recorded, please? If anybody is recording it, please do record it and then share it with everyone. I'm more than happy with you recording this and then sharing it among yourselves. I don't know how to do it myself. I'll make sure that the remaining sessions are recorded. And again, if anyone has any questions, I'll pass the slides on as well. So hopefully we'll get. Yes, I see a couple of questions. Please put it in the chat or speak up. Or you guys are answering. Okay, I'm sorry. I'm just trying to.
Actually, Shaheer, I have a video of how to calculate the score from YouTube. If you want, I can send the link down there. So for whoever is doing that.
Yeah. You can just put it on the chat. I have no issues with that. That would be very helpful. Thank you so much. So you can also have a look at that later as well. But again, so you have these vitals, and then you just put them in the box where the vitals go. And you can see that it's changed. The before, like here, the saturation was in the white box, but now it's in a yellow box, so it's scoring a 1. And I can't even see the numbers, but I just know that's how it goes. So you just do that all the way to the bottom, and then you get a score. I think it's 5, if I remember correctly. So now the situation has changed completely. So this patient was probably doing okay, but now suddenly, their respiratory requirement's gone up, their blood pressure's gone a little bit lower. They're still alert, but their heart rate's gone. They've become tachycardic. So now they're news 5. Now, the advantage of this is now the system that's in place will get a doctor to come see this patient. There's no way that this patient will not be seen by a doctor. And it's good, because otherwise people get frazzled and they're just like, oh, do I call a doctor? Do I not call a doctor? 22 is okay. It's borderline. Blood pressure is over 100. Do I call a doctor? Do I call not? Now we have an objective way of saying, yes, please call a doctor to see this patient. And then probably after that, they'll do hourly obs. That's usually what we do when a patient starts deteriorating. So then let's say we did another set of obs and, oh my God, this patient's respiratory requirements is through the roof and they're given oxygen, but they're still not saturating well. Their blood pressure has gone down. They're confused now. They've got a fever. What news do they have? So you can see now, if you trend all the vitals that are given, their news is now news 15. Okay, obviously, you're not going to get anything this dramatic in real life. This is not how patients deteriorate. They do this over a longer period of time, so please don't freak out. I'm not trying to freak anybody out. But it's just to make you aware, what is the benefit of the news score? Is that we caught this patient at 2 p.m., not 3 p.m. We caught them before they crashed because there was a system in place that said somebody should see this person before they get worse. Does anybody know a disease that can cause this presentation, though? This is not something that I made up. This is something that I did actually see. This might be a very mean question because well, I'll just tell you guys. So pancreatitis can sometimes do this. I've seen this in a patient who was fine. He was chilling, and then suddenly, he just needs a bit of oxygen and fluids, okay. And then he went south, and we had to shift him to ICU. So just, these things happen. But again, we were already on his case by 2 p.m. Like it's not like he suddenly was somebody caught, oh my God, doctor, he's crashing. That doesn't happen. You have signs that somebody's getting unwell. So this is just how you use the news sheet and the news scoring system. I just wanted to show you this. So in our hospital, I got this from our intranet. This is the protocol for when nurses should call, or anybody should call someone to review a patient. So we have a rule that if any patient has a news higher than a 7, a senior registrar needs to be made aware. We're not leaving this with the juniors. A senior needs to come. If they don't need to come, but they need to at least be aware. And then on top of that, they also need to notify CCOT, which is Critical Care Outreach Team, which is basically a group of nurses that work in the ICU. And they're used to seeing patients who get sick. So they have a lot of experience, and we call them in a lot. A lot of times they'll come and we'll talk to them and we both don't know what to do and we'll just escalate. But that's fine because at least we're following up the patient. We know we know they're deteriorating and we're getting more people to help. So this is just how that works. I think another thing I wanted to point out, in the UK, everything's 24-hour clock. So we don't ever write PM, AM, PM. That's not something that we do. It's always 24-hour clock. So it's always 1800 to 2022, just so that there's no confusion. Oh, was it AM or PM? We don't do that here. And then I'm going to talk about something which hopefully will be phased out by the time half of you guys are in the UK, but this is called the bleep system. So I don't know how many of you guys have seen this, but this is a bleep. I actually might have mine here with me. 1 second. I should have prepared better for this. But basically it's a device. It's like because of privacy and all of that, people don't hand out their cell phones. I know they do in Bahrain. Everyone used to have my cell phone. It was a lot easier. But you have a bleep, and it's a fun device, I guess. It makes noise, and people can bleep you. The way that works is every hospital has a code. So on my hospital, it's like you press 10, then the number you want to bleep. So my number is 1007. So if someone wanted to bleep me, they'd just do 1007. And then they would say the number of the phone that they just used. And usually it's on the phone. And then what that would do is they would send me a message saying, hey, you've got a bleep from phone number 4512, for example. This was a bleep I got from one of the wards. And what I have to do is, hopefully, ideally within the next 5 to 10 minutes, if I'm free, I should call back that number, and whoever wanted to talk to me should be on the other end. It's really archaic. It's really bad because obviously if I'm busy and I come back like 30 minutes later, if I call that number, it's just going to a phone that's just sitting there. The chances that the person I wanted to talk to or wanted to talk to me is gone is very high. So they have thankfully phased that out, and they've given us iPhones. I can't open mine. I forgot my password, to be honest. Mine's locked. But and they're not using it yet. But the plan is that they will hopefully make it that everyone has their own number on the system, and they can just call everybody. directly, and it's a lot more efficient. But at the moment, we're still using bleeps. So I just wanted to introduce how bleeps work. So again, you put the code, you put who you want to call, then you put the phone you're calling, and they'll call you back. It was something new to me when I first joined, so I thought it'd be helpful to go through. So next, I'm going to cheat a little bit, and we're going to watch a video. I know, really boring, but this is, I think, the best way for you guys to understand how an A2E assessment works. So hopefully this works. So let's watch this together.
Yes, my name's Alice. I'm one of the anesthetists. We're just going to run through a scenario on an unwell patient in A2E.
I just want to confirm, can everybody hear that? There's no echoing?
Yes, all good.
Fantastic. All right, enjoy.
My name's Amin.
Okay.
My name's Amin. I'm one of the ITU doctors, and I'm going to be enacting the scenario.
And we've got Dev, who's going to be our nurse in the scenario as well. So in a minute, I'm going to do a handover to Amin, and he's going to start assessing the patient. So, Amin, it's Saturday morning at 9 o'clock on the gastro ward, and you are the Foundation Year 1 who's been called by the nurse. She tells you that there is a 56-year-old female admitted for alcohol withdrawal seizures. We've had 100 mils of fresh blood-stained vomit. This is the second episode in the last 4 hours. Apparently, the nurse asked the night staff to hand it over, but they haven't. Bloods were sent earlier in the evening, including a cross-match, and the patient has one IV access with a pink cannula. You ask for the observations over the phone, and she tells you that the respiratory rate was 22, the SATs were 96% on air, the heart rate was 107, the blood pressure was 103/70, and the temperature is 36.5. And she's asking you to go and see the patient.
Okay. Right. So I'm just going to go up to the patient on board to introduce myself. So hi, my name is Amin. I'm one of the ITU doctors. How are you doing?
Yeah, I'm alright. I'm just feeling a bit sick and I've got some stomach pain.
Okay. Can I just confirm that your name is Jamie Smith?
Yeah, that's me.
Okay, perfect. So Jamie, I'm just going to ask you a few questions to see how you're doing and then examine you if that's okay.
Mm-hmm.
So can you tell me more about this pain?
So it's just sort of right in my upper stomach. I've had it for the last sort of 24 hours, but I think it's getting worse.
Okay. And you're vomiting as well, is that correct?
Yeah, I've just had a couple in the last sort of couple of hours.
Okay, and has there been anything unusual there, like blood?
The nurse said she thought it looked like it had some blood in it when she took it away from me.
Okay, fine. And is it just the last 2 times that you've had blood there?
Yeah.
Okay, fine. I'm just going to ask you a few more questions about your medical history. Do you know what medical problems you've been diagnosed with?
I've got some liver problems from my drinking problem, but other than that, I'm fit and well.
Okay. And do you drink quite heavily?
Drink about a litre of vodka a day, and sometimes a couple of cider or beers on top of that.
Okay, fine. And do you take any regular medications?
Just the vitamins and minerals they usually put you on for alcohol stuff.
Okay. Are you allergic to anything?
No.
Okay. Fine. Are you on any blood thinning medications?
No.
Okay. Fine. So I'm just going to do a few more checks, get the nurse to do a few checks as well, and then I'll come back and examine you if that's okay.
Yeah.
So hi nurse, my name's Amin, one of the doctors here. Would it be possible to get some up-to-date observations on this patient? So Jamie, I'm just going to examine you. So I'm going to start by talking out loud and talking about my findings. So just ignore me when I do that. So I'm going to examine this patient by an A2E approach. So starting with the airway, you can see that the patient's airway is intact because they're speaking full sentences. Moving on to assess their breathing. I'm going to first of all observe by the bedside. I can see that the patient's not in any respiratory distress. There's good air entry. There's good chest movements bilaterally, equal expansion. Going on to assess that further. I'm just going to put my hands around your chest for a moment. You can see chest expansion is good. And the coughing is good bilaterally. chest is clear with good air entry pilot. Okay. So I can see that the patient's hypotensive. So just to complete my examination of the circulation now, you can feel the peripheries are warm and well perfused at this point in time. The capillary refill time centrally. If I press down on the chest for a few seconds, just over the sternum, once I remove my fingers, I'm going to count the seconds it takes for the collector to return to normal. And that in this case is 1, 2, 3 seconds. Blood pressure I can see is low at this point. I'm going to, because the patient's unwell, I'm going to start my interventions as I go through with the assessment. So at this point in time, I'm going to ask the nurse if they could kindly put in some cannulae. So if I could get 2 large bulk cannulae, 1 in each antecubital fossa. With the first one, if you could take the bloods as well. So if you could send off a VBG, cross-match 2 units, a full blood count using these and LFTs as well, please. In the second cannula, I'd like to get some fluids going through. That would be good blood pressure. So I'd like 1 litre of harmons to go through via the second cannula. Okay. Just going back to the airway, I can see even though the patient's airway is fine, there's no specific breathing issues at present. Because there's an unwell patient with anyone in this situation, we're going to give them 15 litres of oxygen by non-breathe mask. I'm just going to continue with my assessment as well. So moving on to D, the GCS for this patient is 15, as I established with the history. The patient's glucose would be good to know, but you can see that we're giving the EVG, so we can find out from that. Moving on to exposure, I'd like to adequately expose the patient. Check that that's half of 1 litre. Yeah, that's good. So moving on to expose the patient, I'm going to, with the help of my shutter look to see if I'm missing anything that could be suspicious. So Jamie, I'm just going to have a look under the sheet.
And as you take that off, you see 200 mils of melina in the bed there.
Okay, fine. So that's important to know that there's melina under the patient's bed sheet. For the rest of my exposure examination, I'm going to have a look at the abdomen. So, looking carefully at the abdomen, I'm going to then palpate. So, Jamie, I'm going to have a feel of your tummy. Let me know if there's any pain when I press that.
Not too bad. Oh yeah, that really hurts. That really hurts too. Oh yeah. Not too bad there.
The tummy is soft, but I can see that there's epigastric tenderness on palpation. And listening for bowel sounds.
Bowel sounds are sluggish.
Sorry?
Bowel sounds are sluggish.
Bowel sounds are sluggish, okay. So, at this point in time, I'm going to reassess the patient if we need to approach again. So, Jamie, can you hear me?
Yeah, I can.
Fine.
I feel a bit sick.
Okay, so we're going to give you something for that in a moment. I'm just going to go through the examination again. Okay, so it's the airway still patent, patient saturations 95% on 15 litres. I have no concerns with patient's breathing. With the circulation, patient's capillary refill time was prolonged. The patient's hypotensive. We've got some fluids running, which are hopefully trying to correct that. We've got some investigations being sent off in the form of bloods and osmometer as well. Moving on to the rest of the examination, the patient's abdomen was tender and there was a pool of blood, melina, around the bedside, about 200 mils. So at this point in time, I would like to give the patient, have a look at the patient's records and look at their drug card, just to make sure I'm not missing anything there.
What are you looking for on the drug card?
So specifically, I'm looking for any anticoagulation, any anticoagulant agents which may have contributed to this bleed. And from the drug card, I can see that the patient is only on vitamins and omeprazole. I'd like to prescribe this patient some omeprazole now in form of IV omeprazole, 40 milligrams. Okay. And possibly some antiemetics for this patient as well, seeing if people sick. I'd also consider some analgesia as well. Now that I've done that, I would like to speak to a senior colleague of mine. So I'd like to call my medical registrar. So I'm going to go over to the phone and bleep them.
Please enter user number.
You then enter the patient's bleep, not the patient, the doctor's bleep. So in this case, it would be 890. After that's done, you'd enter the 4-digit number for this phone, which in this case is 76759. So once that's done, I wait for the patient for the doctor's response. Hello?
Hi there, can I see the med reg?
Hi, it's Amin. I'm one of the foundation doctors. I've just come to see an unwell patient. Is it okay if I tell you about them?
Yeah, that's fine, sure.
So I've got a 56-year-old lady, Jamie Smith, who was admitted with abdominal pain and vomiting. I've come to see her because she's had a massive GI bleed. She was quite unstable. When I approached her, I found her to have an intact airway, no breathing issues, but with her circulation she was hypotensive with a prolonged capillary refill time. She's got a GCS of 15. She's got an abdominal tenderness epigastric, as well as pooling of melena by bedside, about 200 mils. So far, I've started her on 15 litres of oxygen via non-rebreathe mask. We've got 2 large bore cannula in the antecubital fossa. We've started fluids, 1 litre of Hartmann's running through, and sent off bloods, cross-matching a BBG. The patient's new score is currently a 5. I've prescribed some omeprazole intravenously and some antiemetics for the time being as well. Is there anything you'd like me to do for the time being?
First of all, thank you. That sounds like excellent management. So what I'd like you to do is list the patient for an urgent endoscopy via portal, and also if you wouldn't mind getting the patient catheterized and starting it through that, and then I'll come and review.
Okay, I will do. Thank you.
Thank you. Bye.
So that's the initial management from a foundation doctor's point of view. I've escalated for help. The other things I could probably do now is just have a thorough look at their previous records as well.
Good. Well done, thank you very much. So that was a beautiful example of a very slick and detailed A2E assessment and management of a GI bleed. So Amin did everything very well and thoroughly and responded to the signs that he was getting as he was going through, and he made sure he kept reassessing the patient every time he did an intervention to make sure there was nothing that was changing as we were progressing through the scenario. He correctly identified a sick patient, he correctly identified the diagnosis and started appropriate management for the patient, and then recognising the patient was sick, he also called for a senior backup and handed over in a very beautiful S-bar handover, and got some further management plans from the medical registrar on call. The only other things to mention with before you leave the patient bedside after you've completed all the jobs is just to make sure that the nursing staff know exactly what they need to do. So ask them to do a fluid balance chart, how often you want your observations being done, and then to just document very thoroughly in the notes. So everything that you found, everything that you did, and then the management plans going forward and handing over to the appropriate teams. We have a urgent bleeders list here, which is booked via portal, and it's an endoscopy for people who are having GI bleeds that usually get done the next day or if not the day after. If you think that the patient needs to be in a high observation area, then the best thing to do is talk to the med reg and the site matron, who might be able to move them to a more appropriate place if you think that they're very sick. And if in any doubt, if you think the blood loss is over a litre, then you can always activate the major hemorrhage protocol, which you do via 2222, and you just say code red, which activates a whole team of people and a porter and lets the blood bank know that we need some urgent O negative blood. He will then talk to you further about what your products need as it progresses. The only other thing to mention, obviously, with liver patients, we had an alcohol history, is just check their coagulation, because obviously they're often coagulopathic. So early discussions with the haematologists and discussing different blood products and replacing things as necessary.
Alrighty, I know that was a lot, so please don't freak out. I have personally seen like 4 or 5 of these videos. There's loads on YouTube, and then there's a couple that your trust will provide you. There's like videos that you need to see before you join and all of that. Am I still connected? Hello? Hello? Oh, yeah, hi, sorry. Yeah, sorry. Yeah, so Yeah, so there's a couple of those videos, and you're not going to learn it all at once. But I'm just trying to give you an introduction to this, so that when you show up and you have to do this for the first time, you have a little bit of an idea of what you're doing. It'll always be scary the first time. The first time I had to do an A to E assessment, it was on a patient whose blood pressure went a little bit low, and it was really funny because it was my first time, and it was my junior F1's first time. And we're both just like bouncing off. It's like, okay, airway patent, yeah, airway patent, breathing, yes, saturation 97%, yes, good, okay, like we just, because we were so scared, both of us were so scared. And the only reason, like, literally their blood pressure was just low, and the patient, by the way, passed out. He was completely passed out. He was completely fine. He didn't care what we were doing, and all we had to do was give him fluids because he was dehydrated. Nobody gave him any fluids. And while we were there, we just, like, the nurse came in. She's calm. We're like freaking out. Like, are we missing anything? Did we check the blood sugar? And we're thinking as if like it's like a code or something. And we started the fluids, and the blood pressure went back to normal, and everything was fine. And we just looked at each other like, we're like, because it's scary the first time. But again, don't worry. Everybody knows it's your first time, and everyone's going to be nice. I saw the comment about getting bullied in the first 2 weeks. Yes, it can happen, but equally, there's so many different people that even if there's one person or two people who aren't willing to accommodate the fact that you're new, there are, there's so many other people who are more than, happy to help you. And things that are routine to them might be really scary to you. So, like, for me, the first time that I had to take bloods from a patient, I was terrified. But then, obviously, literally anybody else was like, all right, man, just come watch. And you learn it. This is all a learning process. This is a lifelong thing. This is not just, oh, I just need to pass the next exam. I just need to get the next. It doesn't matter. You'll be consultant, and there'll still be cases. This morning, I'm post my night shift, and this morning my consultant said, I have no idea what to do with this patient. Where is the other reg? What do you think we should do? Because you don't know. There's things that happen that you don't know what to do. Anyway, I'm going to try to just zoom past it, but there's one other point why I think the A to E assessment is really important. If you apply for standalone, which is what I did, I think most of you probably will go the direct route, but if you apply for standalone, there is an interview. And in my interview, one of the questions, one of the stations was, there's a patient who's been admitted overnight, and they're booked for surgery in the morning, but they're complaining of increased pain. I think it was a tibia fracture, and they're now complaining of increased pain. So obviously you're thinking about compartment syndrome. But I didn't approach it and just say, oh, the patient has compartment syndrome, we need to do a fasciotomy. You don't do that, because what if it's not? What if it's something else? How would you know that? I don't know. Well, that's why you do an A to E assessment. So I said, okay, I'm going to come and see the patient. I'm going to make sure that they're clear, airway, patent, breathing, normal, whatever. You run through it. That's the way that they showed you. I could tell you all about it, but you've seen it yourself. Watch a couple more videos and you'll get it. But hopefully that just orients you a little bit. I think most of us here are from RCSI. Maybe someone else is joining. They're more than welcome. But the nice thing about RCSI is they've always taught us, whether or not you're aware, they've always taught you in a very systematic way. And it comes through. It really, really comes through in the hospital. So don't worry, you'll figure it out one way or another. Abigail, do you want to add anything? Your hand's up.
Yeah, I was just going to say, like, for the A to E assessment, yeah, although a lot of you will be going through the direct route, you're not going to join FY2 directly. However, if you are, from the day you graduate to the day you start work, it's more than 2 years, you have to take something called NCA. I will explain about that in a later lecture, but the A to E will definitely come out in the NCA exam, and you must learn it according to what Shaheer has. I actually watched the same video and I left a comment in that video, so it is very, very important that you do that.
And again, they don't bring it up in medical school, so I thought I'd give you a little taste of what's going to come. We'll just run through the rest. I'm so sorry, we might run a little bit over, but you guys are more than welcome to leave it at any time. So this is just ISBAR 3. You probably have already heard about it. It's very important because a lot of times I'll get a phone call and saying, hi, doctor, there's a patient here. They're spiking fever 38. Now, I don't know who's calling me. I don't know where they're calling me. I don't know if this patient is my patient. And I don't know what problems they could have. I don't know if the patient's been spiking fever all day. They want me to solve the problem. I understand their concern. And I always tell them, okay, let's, can we just start from the beginning? Okay, who is calling? So rather than having this whole process, and I'd like to think that I'm willing to listen. There's a lot of people who just be like, I'm sorry, I'm not listening to this, and they close the phone, which is not right. Never do that. But the way around that is ISBAR. So always identify who you are, okay, where you're calling from, what's going on, what is the urgent thing that's happening right now? My patient is bleeding. I worry they're sick, they're confused, whatever. And then what is this a background of? A patient who's been sick all day and is now still sick is different than a patient who's been fine all day and is now, well, or a patient who has an underlying disease has now, gotten a new problem or a new symptom. That is relevant information. So that is always worth mentioning. And then your assessment. So even at any level, you should always start thinking in your mind, what is going on? This is not the senior's problem that, I'm just a medical student. I just need to know my history and I did a good examination. I'm good. You are good for now, but one day it's going to come to you. What do you think's wrong with the patient? So start practicing now. Even if you're wrong, who cares if you're wrong? That's not your job. Your job is to do history examination. But that's what you're going to do later. So start learning the things that you're going to do later. Make an assessment. This is what I think is wrong with the patient. And then make a recommendation. What's it going to hurt? I think we should start IV fluids. That's a great idea. Why don't we start IV fluids? I think we should give paracetamol. That's a great idea. Why don't we give paracetamol? What's wrong with that? No one's going to yell at you. If they yell at you, it's a problem with them. It's not a problem with you. At least in your own mind, you should have that resolve that I'm going to make a plan. I'm going to assess the patient. I'm going to make a plan. And then read back is very difficult because it's hard to be like, okay, now can you tell me what all the things that I told you back to me? No one's going to do that. But I think there are ways around this. If you just ask someone, I'm sorry, did I tell you about this? And then they will tell you. Or you can kind of mess with them and be like, the blood pressure was 90/40, right? And they'll be like, what? No, it wasn't. And then they'll correct you, And then the last thing is risk. So I always love asking, this is like, is there anything that you would like me to do more? Is there anything that you're concerned about? Is there anything that I'm missing? Very important questions to ask. Abigail.
Yeah, so for the read back, right, if you're talking to a consultant, you can't just ask them, can you repeat to me? It's offensive, obviously. So the way I was taught I did the MRCS prep course, so you can ask them, it's like, just in case if I missed out anything, do you mind repeating to me? You put the responsibility on yourself, so it doesn't look like you're being offensive to them. So just ask, just in case if I missed out anything, do you mind repeating it to me? Then it's much more nicer. They usually just let you go. They'll tell you what is it.
Yeah, and again, we're a team. Okay, this is not a individual sport. There are lots of support. You're not going to be by yourself. I know that's the biggest thing in your mind. It's like, oh my God, how am I going to do an ADE assessment by myself? I'm going to mess something up. They might die. I get that. I had the same thing. And I'm in surgery, so I really thought they would die. I was like, they're going to die for sure. But things that kill people are not that often, and when they are, there are seniors present all the time, and it's not going to be because of you, okay? It'll be because of another reason. And that's a great segue into what do we do when patients die. So somebody needs to confirm the patient. So you might get a call in the morning saying, good morning, doctor. Are you part of Mrs. Smith's team? Oh, hi, this is the senior nurse, Kathy, from Sandringham Ward. A patient has just passed away. Can you come verify the death? I've changed the names around, but this is basically what happened to me one morning. And I was like, I have no idea what to do. But by this point, I had learned that if you just say, oh, yeah, I'm on my way, and then take like maybe 10 minutes, and while in those 10 minutes, you're just on Google saying, how do I do this thing that I'm supposed to apparently be able to do, but I have no idea how to do it. I've never done it before. And, oh, look, Geeky Med, it's fantastic. And then you just read the article, and then you walk in, and you pretend as if you've done 10 of these, even though this is your first one. Mine was really bad because there was the family there as well, and it was my first one ever doing it, and I'm there going, Mr. Smith, hi, Mr. Smith, are you there? Mr. Smith, and it's literally like, anyway, hopefully that will never happen to you, but that happened to me, and I thought I'd just share it. So how do you approach this? So this will be a really bad slide because it has a lot of things in it, but this is basically the steps, okay? You wash your hands and you wear PPE, so like a gown and gloves, You confirm that it's the right patient. The worst thing ever is you go to the wrong bed because usually you get called to a ward that you aren't usually into. Imagine you go into the wrong bed, the patient's asleep, but you go into them and you're like, Mr. Smith, are you Mr. Smith? And then they wake up. Imagine they wake up. You went to go and check if this patient was dead and they wake up. Okay? So make sure it's the right patient. And then you see, obviously, if they're awake, they're alive, they're breathing or not. And then you have to use verbal stimuli. So you actually have to say, hello, Mr. Smith, can you hear me? Are you there? And then you have to check for pressure. Me personally, I like the trapezius squeeze, but it's up to you. You can just apply pressure to the fingernail. Works. You can do the supraorbital one as well. They don't respond, obviously, because they're not there. But if they do respond, then that's a whole different conversation. But most of the time, also the nurses are good. They know when, sternal rub's a good one. Just any way to just see, are they responding to pain? Yes, no. And again, nurses are really good. They've seen so many. They will not call you to sort of verify a death if it's not actually a real death. Then you check their pupillary reflexes using a pen torch. So you just see if there's any dilate or any reactivity to light. You will literally see that they're fixed and dilated and there's no reaction to light whatsoever. You palpate for, I think, a minute. And then you auscultate for heart sounds 2 minutes, breathing 3 minutes. And then you just check the time. Well, yeah, you check the time and be like, okay, this is the time that they've passed away. And then you walk out of the room, wash your hands, close the door, draw the blinds, all of that stuff. The nurses will take care of that part. That's no problem. But obviously, you've done this part. So now the patient has been confirmed that they're dead. Until you as a doctor do this, until a doctor does this, they're not dead. So this is why it's something that needs to be done. I do want to emphasize, though, this is not urgent. You can leave. I mean, it's not ideal, but you can leave them for like 4 or 5 hours without confirming the death. But the time of death is when the doctor comes and confirms that they're dead. Before that, they're still alive. I mean, legally. Anyway, so the next slide will be, how do you document this? I have pretty much copy-pasted this verbatim from Geeky Medics. So again, if you're like, oh my God, where am I going to get access to this later? It's on Geeky Medics as well. But basically, this is the note. I wish my handwriting was this clear, but it's not. The important things, always writing any note, date and time, always. It doesn't matter. It doesn't matter what you're writing. Even if you're writing patient went home, you have to write the date and time. Who you are is very important, because if I feel personally, this is a personal preference. Some people will be like, Dr. Adam. Now, if I randomly come and see the note, if I don't personally know Dr. Adam, I have no idea who Dr. Adam is. It's better to write your rank. So, general surgery SHO note. Oh, okay. Anybody reads it, they know what team they're part of and what level all of this opinion, all of this comments coming from. And then ATSP stands for asked to see patient regarding death confirmation. You'll be asked to see patient regarding many things like vomiting, pain, fever, whatever. But that's just how you document things. I was asked to see the patient regarding this. And then you identify, then you just write basically all the things you did. You identified it was them. They're in bed, closed eyes, no signs of life, no respiratory effort, no response to verbal stimuli, no painful stimuli, cardiac pulse palpable, pupils fixed dilated, no heart sounds, no breathing. Death confirmed at whatever time you actually did it. Now I messed up here. What it really should have been is that this time would be more than this time, but I messed up. My bad. And then no concerns from staff members or patient's family, which is usually the case. And then you just stamp. So I have a stamp that actually looks like this, and then this is my signature, and then my bleep. And then that way anybody can contact me if they need to, which usually they don't. But it's good. So this is how you write a note for someone who has passed away. I'm gonna really try to wrap things up, guys. So please bear with me. So this is just the key apps that I think are really helpful if you want to work in the UK. So there's induction, which is helpful because all the numbers of all the departments and all the people are on induction. Microguide is really helpful for all the antibiotics in your trust. Now, again, it's different from trust to trust, but these apps let you sign into your trust. So the things that they'll show you is the things relevant to where you're practicing. BNF app, very important. I don't know half the doses for half the things I prescribe every day, which is really sad, but I always check, so I'm never wrong, which is, I guess, safer for the patient. I am a doctor. I'm not a pharmacist, so that's my defense to that. MedCalc is for all the things that, like all the grades and scales and things. When people walk in and be like, oh yeah, that's this score 5, and I'm like, I have no idea what you're saying, but I'm gonna go look that up. and then I will come back with another score that you've never heard of, and then we're gonna go back and forth. But I'm just kidding. But all the stuff can be found there. Up to Date is really helpful for when you just can't find the guideline. Like one night there was this patient who was really sick, and their blood pressure was really low, and we're pumping them with fluids, and we're just like, I don't know what to do. CCOT's like, I don't know what to do. And then they come to me like, doctor, what's the most fluid we can give in like 2 hours? And I'm like, I have no idea, but that's a really good question. And there's no guideline for it. So I went to Up to Date and I found out apparently you can give 3 liters in 2 hours and it's fine. So we did that. It didn't help. But anyway, Revolut is really helpful. I'm not getting paid for this, but Revolut I think is really cool because there's a lot of features we'll go into. Super Shift is really nice. It's a great app for just keeping track of when you have work, and then also you can add little like reminders and stuff. Like this meeting today, I had it on my thing. Tesco app is really helpful. A lot of people I know who came to UK were just going and walking to get groceries. You can just get it delivered to your house. I'm just joking around. So induction, this is basically what it looks like once you're logged into your hospital. Let's say you wanted to access A&E, you want to call the A&E phone. That's the number there. So now you know who to call. Anyone in specific, you can call CT, radiology, pathology, the consultants directly. Well, usually consultants directly, you can just ask switchboard. But anyway, you can find it on induction. Microguide is basically how we know what antibiotics to give, because obviously there's different sensitivities in different areas and different hospitals. So the microbiologists have thankfully updated this app, and we can usually get what we're looking for without too much difficulty. My advice to you before calling microbiology is just look through the app. The answer usually is there, unless it literally says discuss with microbiology. Try not to give them a call, because they'll just be like, why didn't you just look at the app? The answer's right there. And they're right. The answer usually is right there. For example, I prescribed this earlier today, actually, for a patient who had appendicitis. So we use AMG in our trust, which is amoxicillin, gentamicin, and metronidazole. But you can find that. I don't even need to know it. I don't even need to remember the doses or anything. It's all there. So it's helpful to have that on hand. BNF, I think all of you have physical BNFs, but there is an app for it. I don't know if it works outside of the UK, but it's very, very helpful. You can look any drug. The most important thing is the indications and the doses. They're all there, and you just copy paste. Oh yeah, fantastic. Okay, there we go. Yeah, so download it, use it. There's a lot of things that RCSI gives you which nobody uses. Like I know a lot of people don't use their Up to Date subscription. I know a lot of people don't use their magazine journal subscriptions. Like we have a lot of access from RCSI, which most people pay for, and we don't take advantage of it. So please do it. Use it. MedCalc, I think a lot of you probably used this before. Very helpful just to grade things. We use it a lot. I used it earlier today to get Glasgow Emery scoring for somebody who had pancreatitis. It was they're just old. That's it. Not severe. Basically, you want to find out if it's severe or not. So it's all there. You don't have to think about it too much. Up to Date, I really hope all of you have used Up to Date. Like, I don't think I would have passed medical school without Up to Date, or even my master's without Up to Date, because it has so much useful information. My advice to you, if you guys are not aware, most of the sections, if you go to the outline and you just scroll to the bottom, usually it says algorithm, and I literally just go there and it just has a nice flow chart of what you're supposed to do. You don't need to read anything. I like pictures because I don't like to read, so it's really helpful. This is going to be the non-academic / medical stuff. So Revolut's really cool. I get paid 2 days early, which is really nice, before payday. So everyone's like getting excited for payday, and I've already gotten my money in my bank account. The other really useful thing is that I didn't have a house when I came here for like the first month, because I live in the middle of nowhere and getting a house is really difficult. So I couldn't get a traditional bank account, couldn't get a Barclays or HSBC. I couldn't open an account. But Revolut, you can. You just need a passport, I think, is all I needed, and a couple of pictures, and they were like, yep, here's your account, here's your sort number, everything's sorted. Hospital started paying me. It's fantastic. It's good stuff. It's really cool because you can open multiple cards. So you can, so I have a digital card, I have a physical card, I have disposable cards, which is really nice. So every time I pay for something, it's just like one-time use, and just like it's really nice. I recommend it for those of you who don't have Revolut. Super Shift is really nice. This is what it looks like. I think I have mine up. I can actually show you. I'm anything too much, but like I can see like all my. So these are all my annual leaves. I've been on annual leave a lot, but like I had night shifts today, and like So I can put all that. And it's really convenient. Like, let's say we go to January and I need to like put some shifts down. So I can just go to shift and then I can say what type of shift it is. And then I don't have to do it. It is free. The subscription I think is like £10 and it's one-time payment and it unlocks like a lot of other features like syncing and it saves everything. I recommend paying for it. It's £10. Like you're not even going to notice, but it really makes my life so much easier. And I think it's really helpful. And then the last one is Tesco. Obviously, I think most people know what Tesco is. You get lots of money back if you have a club card, which you make when you make your account, and they deliver things to your house, which is really helpful. So yeah, that is it from my end. I hope we didn't go too over time there, and that was helpful. Does anybody have any questions? And then if I could please ask for your help, some feedback would be really, really helpful. Just scan the QR code. I promise you it will not take you more than 3 minutes. Like it's literally 4 questions. It's so simple. But if you could fill that out, I'd be very, very, I'd very much appreciate it. If anybody has any questions, feel free to ask on the chat or, open your camera, say hi, hello, anything.